So the skinny on obesity and weight loss surgery. Worldwide, obesity has nearly tripled since 1975, and this could be called our second pandemic, essentially, just in the numbers of people that are inflicted with the disease of obesity. And in 2016, more than 1.9 billion adults worldwide, 18 years or older, were overweight, and of those, over 650 million are obese. And this is a challenge. The challenge is food portion, it's calories within the food, it is weight management and diet control. So how do we calculate weight? Well, weight is a calculation that is termed a BMI, which is weight in kilograms over height in meters square. And that gives you a number, and that number is now your BMI. So what does BMI mean? Well, if your BMI is between 30 to 34.9, you're considered obese. And if your BMI is greater or 40 or greater, you're considered morbidly obese. And you can see the other categories there. So, well then, who qualifies for weight loss surgery? Well, the morbidly obese patient qualifies for weight loss surgery on weight alone. So if your BMI is 40 or greater, you qualify for weight loss surgery, and you are supported in undergoing weight loss surgery. If you're severely obese with a BMI of 35 to 9.9, you need to have an associated illness of obesity. Those comorbid illnesses include like diabetes, hypertension, high cholesterol, osteoarthritis, GERD, sleep apnea, amongst others. And you need a qualifying comorbid condition to have weight loss surgery if your BMI is 35 to 39.9. On occasion, if you are diabetic and you have a BMI from 30 to 34.9, some insurances are covering weight loss surgery for that individual. So that said, the BMI is a relative calculation because this young man, when he was in Austria, Arnold Schwarzenegger, he won Mr. Universe. And in this picture, his BMI calculates to 42. So he qualifies for weight loss surgery, yet his percent body fat is less than 2. But why should I worry? Well, if you're morbidly obese, you have a 10 times increased risk of death in the next 5 years. And there are so many associated comorbid conditions, complications of excess weight, such as heart disease, high cholesterol, cancer, osteoarthritis, liver disease, lung disease. So there's quite an impressive list of medical complications of excess weight. And for every pound you carry in your waist or your middle, it feels like 7 pounds on your hips, knees, and ankles. So if you're 100 pounds overweight, every step you take feels like 700 pounds on those knees. So what is the solution? Well, one solution is weight loss surgery, and this is from the New England Journal of Medicine. And they came out with a position statement after looking at weight loss surgery, and this was several years ago, but their statement states, weight loss surgery together with lifestyle change is the only effective approach for significant long-term sustainable weight loss and weight control for people who are classified morbidly obese with that BMI 40 or greater. So what are the surgical solutions? Well, the 3 surgeries that we perform at Ridgeview Medical Center are the Roux-en-Y gastric bypass, the gastric band, and the sleeve gastrectomy. So if you and I were sitting down in clinic and you're considering weight loss surgery, I would start with a discussion on how the surgeries work, what are the similarities, what are the differences, what are the expectations, what are the possible complications, and such. And I do that just by drawing on a piece of paper. So I videotape myself drawing this out for this presentation. And I like to start with the normal, let me go back. I like to start with the normal stomach. So here I'm drawing the normal stomach. This is what your stomach looks like prior to having surgery. And right below the stomach is where digestion begins. and that is the pancreas, but I'm just going to call that digestion. That normal stomach has an outlet and it has an inlet. So with that, as you eat, your stomach fills with food, and that full stomach then stretches out because of fullness. And what we know to be true is this area of the stomach, when relaxed and empty, sends out hunger signals, and when stretched out in fullness, it sends out fullness hormone. So all three of the operations that I do affect this region of hunger and fullness. All three of those that I mentioned. So if I do the gastric band, I place the band like this. I fill that band with saline, and that filled band then puts pressure on that fullness center. Excuse me. If I do the sleeve gastrectomy, I divide the stomach right through that region, removing 80% of the stomach. And finally, if I do the Roux-en-Y gastric bypass, I'm going to call it the bypass going forward. I make a new, very small stomach the size of my thumb, actual size. Next to it is the old stomach. And of course, in looking at the diagram on the old stomach sizes, digestion, that and the outlet of the stomach. On the new stomach, which I'm going to call the pouch, we now have the inlet. Food that you eat goes into that inlet or that pouch and then has to join up with digestion. And how I do that is I divide the intestine 3 feet further down, bring it up, and I sew it onto that pouch, and then reconnect it to digestion again 3 feet. So the food that you eat now travels 3 feet before finally meeting up with those digestive enzymes. That is where food calories are efficiently. That is causing malabsorption. It's just the length of travel. We have the sleeve and bypass. Now the sleeve, after surgery, you'll be full on 3/4 cup of food, and it is a Thanksgiving meal. You'll not want another bite. Secondly, because I took away those hunger cells, with the band is really dependent on those adjustments, filling that band with saline. Plan on 6 to 8 adjustments in that first. Adjust the band down so that you're eating 3/4 cup of food, staying full 3 to 4 hours, and full on 3/4 cup. The bypass, you'll be full on 1 cup of food, and calories of food that you eat don't absorb as efficiently because we digestion way downstream. So bypass has malabsorption. Okay. So what are your expectations with the sleeve, the band, and the bypass? Well, these are my numbers. My patients lose 75% excess weight in the first year with the sleeve, with weight loss continuing years 2 and 3. Band patients, they lose 41% excess weight in that first year, with weight loss continuing through 5 years or through the adjustment process. But the band companies really set the expectation that band patients likely will need adjustments for the rest of their life. And then the bypass patients, they lose 80% of their excess weight in that first year, with weight loss continuing years 2 and 3. So if you look at the anatomy of the sleeve, you have the normal inlet again, and you have that normal outlet. And so you're going to handle your foods, your liquids, your medications all normally, just in a much smaller quantity. With the band, you have that normal inlet, that normal outlet, but you have kind of a mid-body area of narrowing. And at that area of narrowing, sticky foods, foods that mat, such as bread, rice, and pasta, are going to cause clogging on very small amounts. And so typically untoasted bread, rice, and or any pasta other than angel hair pasta goes away. And in the gastric bypass, you have a fixed opening, 1.5 centimeters here. And so your foods change. You also have malabsorption. Your foods change in which you lose tolerances to fats and sugars. Your liquids change in that liquids flow right through. There is no stop here as there would be in the sleeve or the band. So your liquids flow right through. So if you have a sugary soda drink, you're going to absorb that sugar immediately and you're going to get a sugar high, sugar crash. if you have a cocktail, if you have a glass of wine, that wine is immediately absorbed into the bloodstream. And so both sugar liquids and alcohol drinks, their potency significantly increases. And if you are taking a medication, the medication has to be smaller than 1.5 centimeters to fit through this opening. And it can't be long acting or extended release because the breakdown in the digestive system has changed. And so it needs to be normal preparation. One of the cooler things about my job as a surgeon when I do weight loss surgery is the next day I see resolution of diabetes and hypertension immediately. Patients haven't even lost a pound. And we don't really know why that happens. I kind of call it the miracle of the surgeries. But if you look at the surgeries, there's a common theme, and that is in this area of hunger fullness. Each operation involves that area of hunger and fullness. And the resolution of diabetes is like 80 to 90% following the sleeve and the bypass, 60 to 80% following the band, and 90% following the sleeve, 90% following the bypass for hypertension, and 60 to 80%, excuse me, following the band again. So I'll have a patient come in, undergo a sleeve gastrectomy. They're on 3 diabetic medications and 3 blood pressure medications. And they will leave the hospital maybe on 1 medication, but most likely not having to take medication again because their diabetes and their hypertension will be gone. We recommend vitamins with our operations, and typically that recommendation is lifelong. Unless you have the gastric bypass, then we don't recommend, we require that you take vitamins. And the reason is that this is the area of efficient absorption of, say, iron and calcium, B vitamins, fat-soluble vitamins like D, magnesium, and copper. And so with the sleeve or the band, you have that normal absorption in place. So you're going to be absorbing those important nutrients.
Yeah.
Unfortunately, or maybe not unfortunately, but what has changed in the bypass is that the food that you consume, the nutrition that you're taking in does not go by this area of efficient absorption anymore. And so you have limited absorption of calcium, of iron, of B vitamins, B12, of fat-soluble vitamins, vitamin D, and some trace minerals. And so with that, in about 80 to 90% of patients, if they stop taking their vitamins 5, 10, 15, 20 years out following bypass surgery, they will have pretty serious, significant malnutrition, nutritional illness. So how are the operations? I mean, what are the differences between the operations? And what is, let's just talk about my experience with them and what is happening. So I've done over 900 sleeves, over 550 bands, and over 1,200 bypasses. And December is the month in which everyone wants surgery because they've met their deductibles, and so surgery is free. And so I do probably 20% of my operations just in that December month. Obviously not this last December, but every December previous. And today, or in this era, I'm doing probably 30 sleeves to 2 bands to 5 bypasses in December. The sleeve was an operation that we first were able to do in 2009 and always laparoscopic. The band came on the market in 2005, and again, that surgery is always laparoscopic. And with the bypass, I converted to laparoscopic techniques over the course of 2006 and 7, and at 2007 was only doing the operation laparoscopically as well. So small incisions, safe operations, fast recoveries. The operation is 60 minutes with the sleeve, 40 minutes with the band, and about 2 hours with the bypass. Length of stay in the hospital, 1.2 days with the sleeve, 1 day with the band, and 1.5 with the bypass. And your restrictions following surgery are for 2 weeks with the sleeve and bypass and 3 weeks with the band. The band has this port, as you can see, that is sewn onto the muscle wall. And we ask for an extra week of restrictions just so that can heal in place. What about complications? Oprah says this is such a scary surgery. No, it has way too many complications. Well, these are my complications. I've had no anesthesia complications in well over 2,000, now 600, including revisions and removals and operating on other people's patients. No anesthesia issues. We've had 2 bleeding issues with the sleeve, 1 bleeding issue with the band, and probably 50 plus bleeding issues with the bypass. We've had no infection with the sleeves. We've had 1 infection with the band, and we've had 1 infection with the bypass. We've had an obstruction with the sleeve, and we've had 2 reversals with the bypass, and we've had 3 leaks with the sleeve and no leaks with the band or the bypass. So in all, very, very safe operation, safer than hernia surgeries, appendix surgeries, gallbladder surgeries, with the sleeve less than 0.6%, so below 1% complication rate, band less than 0.4%, and with the bypass, just under 4% complications. And obviously the bypass is a much more complicated operation. And with that, there is a little bit higher complication risk. We've had 2 ulcers with the sleeve, and they have happened following surgery right around 6 months. And typically the history is the patient's a smoker. The band is mechanical. And I've had to repair or replace parts of the band, either the port, the tubing, or the band itself, in about 9 out of 100 patients. And long-term, and these are more long-term complications, we do see small bowel obstructions, ulcers, hernias, and reflux with the bypass. And I should comment on the reflux with the bypass, and that's a little bit of a debatable point because often patients hear that the reflux really follows the sleeve, and it can. And that's why it requires that we do a very in-depth workup of swallowing mechanisms, the origin of the reflux, is there a hiatal hernia, these types of things, so that we know that the sleeve will be a safe operation in someone who presents with reflux. But what we're seeing with the bypass is that seen a few patients in which they're recommending that I reverse the bypass because the pouch is so small that what is happening is that when patients are eating, and they're probably overeating the food quantity that they should, it's starting to stack up in their esophagus. They're weakening that inlet, and they're getting intestinal juice and bile juices that are causing GERD-like symptoms or issues in that esophagus. So that is something that is very new to us, and now I've seen it in probably 4 patients. So which one did you choose? All right. So since 2011 here at Ridgeview Medical Center, we have been a center of excellence. And that maintenance of excellence is certified every 3 years by the American College of Surgeons. Well, what does that mean? Well, here's a paper that I published back in 2016 of my hospital, which is a very similar hospital to Ridgeview. It's a community hospital called Unity, which has changed kind of its focus of care. But back then it was the Centers of Excellence, and I reported that in a Centers of Excellence, a community hospital, surgeries can be performed safely with no mortality and excellent outcomes. And here again, we reviewed the first 10 years of Unity's Center of Excellence experience with more than 4,460 operations and 4 different surgeons. And what we found is that there was no mortality in those first 10 years. That our readmission rates were 4.1%, typically for dehydration most commonly. And the lowest reported average readmission rates were 2.7 to 8.2%. And our overall reoperation rates were 1.1% versus the reported 1.6 to 3.4%. So I think those were excellent results, very proud of those results. These are my results individually in yellow. And this is the result. This is what it's all about. And this is Carrie. She's one of my first band patients. She might have been the 3rd patient I put a band in. That was back in 2005. And I just saw Carrie back in clinic, and she still is weighing right around 126. So wonderful result with her band. She has had some mechanical failure that we've had to address. But yeah, very, very successful. And one of my favorite visits following surgery is that annual visit in which the patient tells me how much their life has changed, how happy they are, and how the quality of life has so improved for them.